So, Dr. Mendrata Lala, thank you very much for this informative lecture. It was really, it had really a lot of good information, and we learned a lot from it. The first question is from Palermo, Dr. Georgia Porello. Georgia, what do you want?
Hello, good evening.
Hi, buonasera.
So, buonasera. And congratulations for this wonderful lecture.
Thank you.
So my question was, in our center in Palermo, we saw that sometimes in the first 6 months, there can be a drop of signal in out-of-phase sequences without the lesion being vital. So I wanted to know what was your experience, if it was something that was seen.
On out-of-phase, you're saying? Out-of-phase imaging?
Yeah, out-of-phase imaging, like if there was some fat inside the lesion, but the lesion was not vital on follow-up imaging.
But you're seeing persistent intracellular lipid centrally in the lesion.
Yeah, exactly. Yeah.
So
So we noticed that it wasn't. Oh, sorry.
No, that's okay. No, go ahead, finish.
No, so we noticed that in the follow-up imaging, those lesions were not vital. So we wanted to know if it was something that could lead to the diagnosis, if it was something that was, sorry, that was observed.
Yeah, so from my experience, I haven't had too many of those, and we can see if Richard or anyone else on online right now can offer their experience. There are a few cases where we've had tumors that did have intracellular lipid pre-therapy, and after treatment, there's no enhancement. Most of the time, I don't see lipid within them because that whole area is non-viable necrotic. Sometimes if I do still see areas of maybe focal residual intracellular lipid, but there's no enhancement, I call those equivocal. But again, I haven't seen too many of them, so I don't know if anyone else wants to offer. I know Richard is on, if he has anything to say about that.
Richard?
Maybe he's not on anymore. Yeah, so I usually call those equivocal and then
Richard,
follow them up.
I think he's going to talk now. Richard?
I'm sorry, I was in the middle of a conversation with a colleague, so I didn't listen to the question.
The question was that if you have a HCC that does have intracellular lipid, you treat it with locoregional therapy, and on the follow-up, there's no enhancement. There's no evidence that there's residual viable disease, but there's still loss of signal on out-of-phase imaging. What do you do with those patients?
I don't think the lipid itself is that useful after treatment. We haven't had any ancillary features in our treatment response algorithm. It's really all based on enhancement. But that could be an interesting question to study. I would expect the lipid to stay behind, let's say, after ablation, because you're not removing the lipid. It may just be there and be a bystander. So I don't think it's a useful ancillary feature, but that's just an opinion. It's not based on facts.
So having mentioned the ancillary features, Dr. Do and Dr. Lala, we know all that the problem with ancillary feature is that they don't have the same weight. So some of them are more significant than others. And what about, in particular for the post-treatment, what about the diffusion weighted? I mean, and even Michelle here has presented some cases with diffusion weighted, and in my experience, I have seen some lesions that the only thing they demonstrate are diffusion restriction. So what's your experience with that, or are you planning to add some ancillary features in the upcoming version?
That's an excellent comment. Michelle, you want to take a stab at it first, or do you want to?
You go first.
So I briefly talked about it in the lecture I gave a week ago or so, or 2 weeks ago now. And there's some evidence that if you use it as an ancillary feature, you increase your sensitivity for viable disease. And I think this is after chemoembolization. I'll have to refer you to that lecture and the reference in it.
It's chemoembolization.
Yeah, the reason we didn't have ancillary features in the first round is we were struggling to even come up with an algorithm, and we wanted to keep it as simple as possible. recognizing that T2 may be useful and other sequences may be useful in the long run, and encouraging the community to come up with that research. So as we revise the chapter on treatment response, it may get more sophisticated and incorporate diffusion as one of the important sequences. Now note that an ablation zone can look diffusion restricted, right? So that was not a reason why we at first stayed away from using diffusion at all. So we need more data, and it may come down to recognizing a diffusion abnormality that matches your area of enhancement that you're equivocal on. So it may be useful more in the setting of an equivocal lesion that shows up on diffusion as a nodular lesion. That can be the tiebreaker that allows you to go back towards viable. So that's just a projection into what may happen, and we need more data to make that decision.
Okay, great. Perhaps we can do some trials to actually look into that. That would be really a very good research question. So we have another question also from Palermo. It looks like, Michelle, that our colleagues from Palermo likes you. Roberto Canella, buonasera, Dr. Canella.
Thank you. Great lecture. My question is about the patient with tumor in vein or infiltrative HCC. How should we deal with this patient? We can use the LI-RADS algorithm, and because sometimes I think it's very difficult for us to see if there is response or not, and sometimes I think the endpoint is not progression rather than complete response.
Right. So, I mean, again, that is those infiltrative HCCs, tumor in vein, those are more challenging. So our current response algorithm doesn't have too much on that, but I think that's, again, a case where you have to really closely examine your pre-treatment imaging, whether it's CT or MR. Look at the extent of the disease in that patient, how much tumor was in the vein, how far along the vein was it, and then look at your post-treatment imaging to see, does it look like it's advanced, meaning there's more progression of tumor in that vein? Is it the same? Other things, when we think of tumor in vein, you think of that expansile appearance of the vein, whereas bland thrombus doesn't really have that expansile appearance. The enhancement, so if you've got a change in the enhancement, it's hypo-enhancing, and before it was hyper-enhancing. Looking at diffusion, again, although diffusion is not part of our algorithm right now, the combination of using that diffusion with your arterial phase imaging and kind of looking at it all can help you decide. And sometimes in those cases, you have to use the equivocal category. They've been treated. Could there be small amounts of viable tumor still there? We're not really sure. And the other confounding factor is, obviously, if you have tumor in vein, you also have large amounts of perfusional changes in the parenchyma related just to the TIV itself. And then you've got your locoregional therapy on top of it. So it makes it even more confusing. So I think just looking really closely at your pre-treatment study to see the actual extent of disease and comparing that to your post-treatment is one of the most important, factors in order to decide whether what your treatment response is. But those are definitely difficult cases.
Okay.
And that's where, again, where the equivocal category comes in handy.
Mm-hmm. Okay, great. Did this answer your question, Roberto?
Yes, I totally agree that there are very difficult cases, and sometimes I think they only expect that there is no progression, but the tumor is still viable because it's so infiltrated that it's very difficult to treat this patient.
Right. Yes.
So our next question from Messi, Egypt, Dr. Eid. Dr. Eid.
Yes. First of all, I would like to thank you very much for the perfect lecture. It explained a lot. There is a question about the case you presented, one of the cases you presented for TACE response assessment. I don't know if you can show it again, because
Sure. You remember which case?
It's in the section of TACE.
Okay.
Transarterial chemoembolization.
Yep.
No, not that one. Not that one. Another one.
Okay.
No.
Hold on.
No.
Nope, those were the ones.
Yes, yes, this one. This
Okay,
one.
yeah.
No, the next one.
Oh. This one? No. Sorry. This
no.
one.
Can you go back, Michelle? I know.
No.
Yeah, I think this one.
Yes, yes.
Go back. Go back.
It's
The small lesion that shows enhancement, rim enhancement.
no, it's not. It's a single large lesion in the right lobe. It's single large lesion in the right lobe.
Oh,
this one.
Yes, this one exactly. This
sorry,
the post-treatment
time
image.
Difference, Michelle. That's why we needed to slow down because there's a time difference between here and Egypt. So
okay.
by
Okay.
the time you scroll, I think it will be. Yeah, go ahead, Mohammed.
Yes, exactly. This one, the post-treatment image, I don't see it as an arterial phase because the aorta is not really bright, and the lesion was hyper. There was a perfect AFI before treatment. I don't see this AFI post-treatment. Why didn't we call it equivocal, at least, not viable? Maybe the phase is not correct, or I don't know.
Yeah, no, you're right. So this, unfortunately, I didn't have the right phase here. So you can see the aorta here and you can see it here. So this is not, I wrote arterial phase. This actually is probably more of a portal venous phase. So it's not, so I should correct that. The reason though is the type of, so even though, so you can see here what necrosis looks like. There's just no enhancement. So even here, it's not arterially enhancing. Well, we know this is not the right phase, but even if you said portal venous, should there be washout, you know that there's still signal in it. It's still enhancing, right? I mean, it's iso enhancing to the parenchyma, so there's still enhancement there. And so given that there's still enhancement in that tumor, you know that there's viable tissue because it was TACE. It's not a radiation therapy. So I guess that's a good point. I should change this arterial here, but there is still enhancement of this.
Okay.
That's the tumor. And so since you have enhancement, you know it's viable.
Okay, because it's not completely necrotic.
Exactly. And so, and this was what it would be if it was necrotic. So even if this was the right, you know, the phase here, the whole thing should be basically black. There should be no enhancement whatsoever, whether it's hyper enhancing or just iso enhancing or even hypo enhancing, there is still enhancement is the point. And so that presence of enhancement, again, whether it's hyper enhancing, iso enhancing, or hypo enhancing, is suggestive of viable tissue.
I see. So, but sticking to the criteria of LI-RAD post-treatment, it should be either hyper enhancing or washout or enhancement like the pre-treatment tumor. This does not fulfill one of these criteria, so maybe equivocal.
Well, I think
you know what I mean.
Yeah, I think I probably just chose not the greatest image to put here, so I should change that for the future. But I think I agree with you. So based on the LI-RADS criteria, we say, let me just go back to that 1 second. No lesional enhancement is non-viable. If we want to say viable, you're going to say hyper enhancement, washout, or enhancement similar to pre-treatment. So I think part of this was it wasn't the same phase, so it's hard to make that.
Okay, that's why.
It's also, if we're going to call it non-viable, we have to say no lesional enhancement, and we know that there was enhancement there. So then you're saying, well, would that be equivocal because it's not that and it's not fitting that? So I guess that's a good point, but I think again, because of the type of therapy it was, because it was a non-radiation intra-arterial therapy, and because we're still seeing enhancement, we would call that viable. I don't know if anyone else wants to speak up, Richard or Claude or Victoria.
I just have a comment. This is Claude. Forgive me, I don't know who it was who asked you to review that case, but I think he made a great observation, a great point, that strictly speaking, according to the treatment response algorithm in LI-RADS, if that had been an arterial phase, so it sounds like it was probably not an arterial phase, but let's just pretend it was an arterial phase, then strictly speaking, that should be equivocal as defined by LI-RADS. Now, I think what you can do sometimes in your own practice is that if you're using LI-RADS and the strict application of the algorithm is equivocal, then I think you would say that. You would say, by strict application of the LI-RADS treatment response algorithm, this is equivocal, but in this particular case, I am very concerned because it looks like the inner enhancement is quite mass-like, and even though it's equivocal, I would want to discuss in multidisciplinary conference, and in that conference I might, advocate for retreatment, even though the LI-RADS response is equivocal. So I just want to congratulate whoever it was who brought up that point, that I thought that was a very astute point. And I think it's very helpful when you bring up points like this, because it shows us where LI-RADS works and sometimes where LI-RADS, maybe could be improved a little bit. So anyway, that's my feedback on that. Richard and Victoria or Khaled, do you have anything else that you'd like to share or add?
No, I
just great observation.
Absolutely agree. That's
great observation. And yes, absolutely right. You have to use judgment and not apply LI-RADS blindly. And when things don't work out the way your intuition tells you, that the imaging is telling you what's going on, then communicate with the referrer directly, or be more explicit in the report. Don't just put on the category and stop there.
So did you like my judgment in people, Claude? I was always telling him Messi Egypt, and he is Messi Egypt, Dr. Eid from Egypt.
Yes,
thank you. Thank you.
Yes, absolutely, yes. And when you say Messi, you're talking about the soccer player, correct? The football player.
Yep. I know you guys don't watch soccer as much as people from Egypt watch, or Europe.
People, the rest of the world.
Yeah.
In the entire world, soccer, or what people call football, what we call soccer, is the most popular sport in most of the world.
Yeah. We call football, it's very interesting because we call football for a sport which is played by hand, not the foot. And
no, I know. Well,
yeah.
Listen, Khaled, the United States, we still don't use the metric system. Okay, so I don't know if everyone understands that, but we still don't use the metric system. So we're definitely behind in many, many ways.
Right. Okay, so any other question? I was expecting a question from India, but my colleagues in India didn't come back with a question.
Can I just make a comment, Khaled? I'm sorry, I know that you usually mind, but you sometimes allow me to.
Yeah. I'm in a good mood now, so go ahead, please.
Okay. Well, once again, I'm struck by the quality and insightfulness of the comments from the people that are participating in your liver webinar, Khaled. And I think the question about fat, for example, is very interesting. If there's fat after treatment, but there's no enhancement, then at least scientifically it's very interesting. So where is that fat? Is the fat still contained with vacuoles within dead hepatocytes? Has the fat leaked out of the cells and is sort of now just triglyceride molecules that are just sort of stuck within this ischemic, post-treatment stroma? Where is it? And so what I would like to suggest, Khaled, because I'd like to give you more work, is that maybe we should organize an international RAD path journal club. Well, not journal club, just club, where once a month or so we can get together and show cases where there is radiology pathology correlation. So the person who was talking about the fat, I don't know who it was who brought it up, but imagine that there's a situation where that gets biopsy.
That's my friend Georgia from Palermo.
Ah, Georgia from Palermo. Okay, but so imagine that lesion gets biopsied or gets resected, and then we'd actually have RAD path correlation. We could learn from one another and say, okay, this is anecdotal. This is only one case, but in this one case, there was fat on MRI after treatment. The lesion ended up being resected or whatever, and notice that in this particular case, this is where the fat was on pathology. The fat was not in cells. There were no live cells, but there was fat. There was fat material interspersed within a necrotic cavity. I'm making this up, obviously, in this particular case. My point is, it might be interesting to have an international RAD-Path club that could meet maybe once a month, and we could show cases in which there's RAD-Path correlation. Food for thought, Khaled. If you don't like the idea, you don't have to do it. But if you like the idea, it's more work for you, and you do such a good job that I would be delighted to participate.
Can I tell you something? Great minds think alike. I was yesterday, seriously, I was thinking about the same idea, where we can come with interesting cases and can just demonstrate them. I didn't think about RAD-Path, but it's going to be obviously RAD-Path. So this is great, and then we can actually have this like some sort of mingling, or maybe people submit the cases beforehand. That would be really nice. So let's do that.
But okay, but make sure not to invite Michelle's friend.
I have to tell you, it's very funny.
My friend.
I'm very inflexible. I'm very inflexible with allowing anyone to enter this meeting. So after the meeting starts, I have several requests to unlock the meeting, but I didn't. Usually in the other days, I would unlock the meeting, but today I didn't. Anyway, so we have a question. We have question here. I've been calling on my Indian friends to ask questions. So there are two questions. One from Sandeep and one from Pradnya. Let's start with Pradnya because of the current era of women and minority. We have to start by the lady here. Dr. Pradnya Mahitar.
Thank you, Dr. Lala, for a great lecture. I just I want to know if you can just give us a short answer to, is there kind of a patient selection criteria for local radiation therapy versus the local therapy like cryo or TACE? And then the fact that the radiation therapy post-treatment scans are very not very clear for a longer time. Does that is that taken into consideration by clinicians when they actually decide on what treatment to get?
Okay, so that's a good question. So I think that really depends on your institution. So a few things. What is the form of therapy most utilized in your institution? It comes down to, what doctors are there, what's approved by your hospital, what everyone's comfortable with. I think it comes down to your multidisciplinary group, the surgeons, hepatologists, oncologists, interventional radiologists, everybody kind of as a group and what they do. At University of Michigan, we have a lot of cases that go for SBRT. We have a very avid radiation oncology division. They had a huge NIH grant. They have a lot of money, a lot of technology, and it was very well accepted by the surgeons and the hepatologists. We also do a lot of thermal ablation and other forms of intra-arterial therapy. So every case is taken to tumor board. I think where we use SBRT now are cases where we can't, where we don't think we have a good access to them via, percutaneous ablation, for example. Or sometimes even our really big HCCs, kind of extensive HCC, where we don't even think that TACE is a good option, we use SBRT. We have a lot of data that shows really, really good overall survival and time to progression, and so we use it quite frequently. So again, like I said, I think it's the comfort level at your institution, what your institution can offer, and a multidisciplinary kind of decision on what to do for the patients. In terms of the imaging findings and does that influence it, I do think that there's not that much literature out there in terms of what is expected and what is your overall survival in these patients. We know after surgical resection, after ablation for lesions less than 3 centimeters, your 5-year survival rate is equivalent, for ablation and surgery is equivalent for smaller tumors. So we have a lot more survival data on these older or these other forms of local regional therapy, and our survival data after SBRT and radioembolization is just starting to come out, so I do think that's a consideration. But I think the places that do a lot of SBRT and from the literature that's coming out, there really is a wonderful result after SBRT. I mean, it's really good. The number of failures and residual disease is very, very low. But again, I think that's, again, it's a call for more data. We need more studies showing that. But there are some studies starting to come out now.
Is it like better tolerated by the patients, like better for the sicker patients than the other therapies, or that's not true?
So not necessarily. So I would say, so it's non-invasive, of course. Now, depending on where you do it, sometimes it's 3 fractions, sometimes it's 5 fractions. They have newer protocols where you can do 1 to 3 fractions for SBRT. But in terms of better tolerated, now, when you do TACE, obviously you are, there's embolization there. So you can cause damage to some normal parenchyma in patients who already have tenuous liver functions. With SBRT, you can also see the effect of the radiation in the surrounding parenchyma. Now, they can give the radiation so it's even more focused, so you have less damage to the surrounding parenchyma, but you will get some changes in the surrounding parenchyma. So there are a few studies out which look at Child-Pugh scores and changes in the first 6 months post-SBRT. And there are, of course, cases, I think, if you're treating patients with a baseline higher CP score, so CP 8 and above, they have more of subtle decompensation immediately post-therapy. I think for patients with CP 7 or child, B7 below, they tend to do better. But again, I think it also has to do with the experience of your radiation oncologist versus your interventional radiologist. So I think all of that has to be a consideration. But most studies out there are showing that Child-Pugh B7 patients and below respond very well. Newer studies are showing that even 8 and 9 respond really well to external beam radiotherapy.
Okay.
I don't know if that answers the question or not.
Yeah, I just have a comment which is slightly, it's not related to my question, is that right now I work in a smaller hospital, and the idea of multidisciplinary tumor board, it really doesn't happen as often. Most of my patients go away somewhere else, and I have many times absolutely no idea as to what happened to them, or I'm reading scans without actually knowing what kind of treatment patient has received, because you really have no access to, the treatment done at like NYU or somewhere else, and they are having these scans regionally. So one of the hindrances to actually use the treatment response system is that you don't know what you're looking for half the time, because you have no patient history. So I just wanted to put that out there, that in an ideal world you would know everything and you have people to discuss with, but many of the regional hospitals, the problem is that things are not as coordinated as they should be.
Yeah, no, and I think that's a great point, because if you don't know what the treatment was, it's really hard to assess treatment response. Like I showed with the intra-arterial therapies, if it's radiation versus non-radiation, it makes a huge difference in how you're going to interpret those patients. One thing that I would say is there are even, at U of M, we get a lot of outside referrals because we're a transplant center, and there are patients that come and we don't have any history, and I get the images to interpret for tumor board. And so the way I will sometimes present it is, based on this imaging appearance, it looks like they had intra-arterial therapy. If it is radiation therapy, then I would call this equivocal, but if it was non-radiation, I would call it non-viable. So I kind of, again, it's one of those things, we were talking about that other TACE case where in your reports, you could, add that caveat that if it was this form of therapy, this is what I'd call it. If it was another form, this is what I would call it. But I really can't make an accurate assessment until I know what form of therapy it was.
Okay, sounds great. Thank you.
Thank you very much, Pratnya. Last question from Sandeep. Sandeep?
Yes. Good evening, sir.
Good evening.
Many congrats for a brilliant lecture. Correctly, basically describing the various imaging findings and all the treatment options that are available. I had a small query. Have you ever experienced portal vein thrombus developing in HCCs who undergo SBRT or in after systemic treatment? because that sometimes creates confusion in our scenarios when we use SBRT as a bridge for patients for liver transplant, because the tumor bed starts showing heterogeneous enhancement, especially in lesions close to the falciparum ligament or the liver hilum. But we start seeing the appearance of portal vein thrombus, and then we are divided that is it really tumor or is it just a secondary to the effect of the SBRT? Any comments, any experience you have on that?
That's a good question. You know, we have quite a bit of SBRT, but I can't say that I've seen post-SBRT tumor thrombus. So I can't answer to that. Are you saying you see tumor thrombus or bland thrombus after? I guess that's a difference.
I know, but sometimes it even gets difficult qualifying it correctly as just a bland thrombus because it's sitting just next to the tumor. So I know that there is no arterial enhancement, the vein is not expanded, but in a scenario like liver transplant, you really get biased or you really get pressurized that is it really tumor or no. So
yeah, no,
this I've seen especially after SBRTs.
Yeah, that's really interesting, and I'd be interested to look at some of those. So I haven't had that experience, to be honest with you, where I've seen that. We do a lot of SBRT on patients with tumor in vein and infiltrative HCC. So of course, but that's a different case than what you're talking about.
Yeah, that's a different case scenario. And in our experience, SBRT patients have done well with tumor portal vein thrombus, where the tumor viability, at least on imaging, looks as if it is gone. Even if it was a PET-avid tumor, the avidity goes down, the arterial enhancement goes down. SBRT does have a role in that area. But
no, I can't say I have seen that too much. I don't know if anyone else on this call has seen that, but I haven't had too much experience on that. But I would be interested to chat with you about that offline, because that seems, I mean, that's very interesting. I think that's very important because, like you said, that could change their transplant eligibility.
Yes, that's the issue.
Yeah. So
thank you anyway.
Yeah, thanks.
Thank you very much, Dr. Mandriata Lala. This was a great lecture, great questions. Also, thank you, the audience here, and we're able to get over that. So this is fantastic. I think I'm so much relieved, and thank you very much for Michelle again for agreeing to come back and give this lecture. That was a great one. I would like to thank our audience from all over the world, and please come back next week. Very nice lectures lined up. We have the first two lectures of the next week are blending very well with today's lecture, because it's about liver interventional procedures, and that would be Monday, and Tuesday will be particularly about Y90, because Dr. Marvash has a special interest in Y90 in our institution. Then we have a lot of other lectures lined up, very nice lectures. We have cholangiocarcinoma by Meg Lubner from Wisconsin, and then we have a pediatric tumor from Alex Tauben from Cincinnati Children. So many lectures, many excellent lectures coming up. So stay with us, and thank you very much again, Michelle, and everybody.
Thank you.
Appreciate it. Bye-bye.
Bye-bye.